All right, well, I see it kind of slowing down a little bit, and I want to be respectful of everybody's time, so I think we're going to go ahead and jump in and get started with our proposed rule, MIPS 2024, what you need to know, specifically targeting our ophthalmology clients and the impact to the specialty in regards to this proposed rule. So again, I'm Heather Miller. I'm one of the senior professional services consultants here at Next Tech. Also joining me is Christy Brantley. And we are going to kind of take you through the next hour and an overview of this new proposed rule. We will be having a Q&A at the end of the session. So any questions that might pop up throughout, if you could pop them into the questions within the webinar meeting controls, then we can definitely address those when we get to the end. And then also we will be releasing a link to the recording of this webinar. I know people always ask, so that will be released upon completion and available for you to view at a later time. So let's get started. First and foremost, just to remind everybody, the information provided in this webinar does not and is not intended to constitute legal or other advice. Instead, all information, content, and materials are available for general informational purposes only. Information in this webinar may not constitute the most up-to-date legal, financial, or other information. Webinar attendees should contact their attorney, financial, tax, or other advisor to obtain advice with respect to any particular matter. This webinar contains links to other third-party websites. Any such links are provided only for convenience, and NextTech does not recommend or endorse the contents of any third-party site. So our agenda for today is first looking at the MIPS proposed changes for the 2024 reporting year. We'll then take a quick look at the MIPS Value Pathways. Then we're going to discuss why you should continue MIPS in 2024, and then move into a live Q&A with Christy and I, your MIPS experts. So before we get started, we're just going to jump in and have our first poll. Make sure everybody's paying attention and ask a quick question. If you are considering MIPS reporting for the first time. And it's crazy, we're in year 5 of this program, so I'm hoping to see that we've got a good majority of people participating.
Looks like it, Heather.
I know, right?
Yeah, looks good.
Still got about 10%, little less than 10% out there that it's your first time reporting MIPS, and really important that you guys get into the game because they're not slowing down. All right, so yep, we're at about a 90-10 split. 4 of you guys are not sure. So if you're on the fence, then definitely ask some questions at the end to see why you can get some confidence in jumping into the MIPS game. All right, so let's move on. MIPS proposed changes for the 2024 reporting year. So there are 3 reporting options. Traditional MIPS, which is how I think the majority of practices will report. Then we've got our MVP, which is the MIPS Value Pathways that first rolled out in 23, will still be a reporting option in the 24 reporting year. And then we have our APM, or Alternative Payment Model Performance Pathways, and they are adding a new collection type. Anybody that does participate in an APM through an ACO, they are looking to add a new collection type, which is Medicare CQMs. These can only be reported under the APPs, but they're meant to streamline some of the inconsistencies in collecting data that they experience because it's coming from multiple different systems. So this is just a way to kind of streamline the aggregation of that data for the APM models. But other than that, traditional MIPS and MIPS Value Pathways are the 2 key ways that we can report to CMS for the 2024 year. Performance threshold for the 24 reporting year is looking to increase. You can see here we've been at 75 for the last 2 reporting years, and it is proposed to move to 82. It is in statute that they have to take the mean of the final scores of a previous reporting year. So they are pulling this average from both the 27 to 2019 average and the 2019 to 2021 average giving us the 82 threshold. So for providers and practices reporting, you're going to need to ensure that you're meeting the 82 points to avoid those negative payment adjustments. Our category weights are not proposed to have any changes. We still have a 30% quality category score. We have a 30% cost, 15% for improvement activities, and 25% for promoting interoperability. So no changes. This is the weight if you report all 4 categories. Now, if you were to reweight a category, there is reweighting requirements or specifications dependent upon which category reweights and where those percentages would go, all available at the QPP website if you need to see those. Penalty adjustments is still going to be at a negative 9% for 0 points. Anything above, it was 18.25 in 23, would still then begin receiving an adjusted amount of that negative payment up to the 75 benchmark. So now we'd be looking at 82 as a 0% neutral adjustment. Anything over 82 could result in a 9% plus adjustment. Now, we all know that the 9% positive adjustment is reflected of the amount of penalties that we see in the coming year. So we know that the negative pays the positive in that budget neutrality component of the penalties. So we could see less than 9%, but it's kind of a basic 9 to 9. So let's talk about the proposed changes in the quality category. Our reporting period is still 12 months, and the reporting requirements are still 6 quality measures, at least 1 high priority or outcome measure required in what is submitted. We are going to see an increase in data completeness. In previous years, we've seen 70%. Meeting the data completeness threshold means that you're going to report a minimum of 75% of your eligible instances for each measure for the entire reporting year. And this is critical for successful MIPS reporting. Remember, it's not just 75% of everything, it's each measure, who's eligible for that instance, dependent upon, again, the measure specifications, and ensuring that you've included 75% or more of those eligibles in your data collection for the quality category. Also in the proposed rule, it has data completeness increasing to 80% in 2027. Looking at the points for quality, we aren't seeing any changes this year. The bulk of these changes we saw last year, but wanted to reiterate this, that a 1 to 10 point scale is for each required measure that can be scored against a benchmark will receive between 1 and 10 measure achievement points. So the bottom line threshold of 3 has been removed and was removed last year. On measures where you don't meet case minimum or data completeness, there is an exception, and small practices can still continue to earn 3, but large practices could receive 0. And then each required measure, but unreported, also would receive 0 points. Looking at the quality measures, we had an addition of 14 new quality measures. There is a proposed removal of 12 quality measures. We have substantial changes to 59 existing quality measures, and we have 3 measures that are moving to the NVP reporting only. So let's look at this in a little bit more detail. Here is the list of the 14 new quality measures. Most of them from the list are not going to be very relevant to the specialty of ophthalmology or retina or any of the next tech supported specialties. Number 6 is the only one that potentially could become of something you consider, but this is a new measure called preventative care and wellness, and it is a composite measure, meaning it's going to include a longer list of individual measures that we'll discuss in just a few slides. Other than that, the other thing we're seeing this year, you'll notice with the dual stars at the end, are patient-reported outcome-based performance measures. So this is the first year they've added measures where patients will actually report and then be scored off of their responses to these particular measures. You'll see here, this is ambulatory care, patient experience of feeling heard and understood. So it's interesting to see them bringing forward some measures where really patients are going to drive the responses and the scoring on these measures. But overall, nothing really new on the horizon for ophthalmology. Now, as far as proposed changes for quality measures with the removal, here is the 12 measures that we're looking for proposed removal. Number 14, AMD, which has already been a topped-out measure. So after a measure has been in a topped-out status for over 2 years, it eventually is then removed from reporting. So we are seeing that in the proposed rule. The influenza and pneumococcal, which were actually moved to MVP only last year, are looking to be proposed removal from the complete list, as they're going to be one of the ones moving under the new composite measure. And then we've got tobacco use for adolescents. I'm not too sure if many practices use this, but that one they're just changing the age of the smoking cessation measure, and they're decreasing it to 12. And then that would consolidate this 402 measure, which right now is 12 to 18. So those are really the main things that we see having potential impact to the ophthalmology, especially and with the removal of measures in 24 proposed. So looking at a couple of the quality measures and the substantive changes. So these might be measures that you all are currently using, and every year we want to just make sure when they change some of the fine, details that you know exactly what they're changing. And as I just spoke, the tobacco cessation is going to be changed where the denominator is an eligible age from 12 years on up, versus right now it would start at 18, and we had the other measure, QPP 402, where they're just combining these patient populations. On the use of high-risk meds of the elderly, they're updating the medication tables for ECQMs to align with current guidelines, and they're adding logic for medications ordered on the same day but intended to start on different dates. So just putting some variation there as to when the meds are really going to come into play. And then on the preventative screening for unhealthy alcohol use, they're just changing the criteria 1 measure versus using criteria 2. So some of those that have different stratas, like smoking status, they're just going to measure the benchmark off of a different criteria. Now, looking into some of the specialty-specific measures on diabetic retinopathy, communication with the physician, managing ongoing diabetes care, they're revising the description to clarify the reporting period is the 12 months from January to December 31st to assist with consistency across MIPS measures. So there's a look back in this measure, and they just want to make sure that they clarify that look back is in the 12 months from January 1 to December 31st, not a look back from the day of the visit, the date of service. On diabetic eye exam, they're updating the denominator exclusion medication list for dementia medications, and they're updating the numerator to include patients who receive services under CPT code 92229. And then under the glaucoma, reduction of intraocular pressure, IOP by 15%, or documentation of plan of care, they are updating the reduction of pressure to be 20% based on some latest scientific evidence. So these three are much more specific to the ophthalmology specialty. And again, just some fine tuning within the parameters of those measures is what's being proposed. Most of these aren't going to be very related, most not doing any high blood pressure or controlling high blood pressure at this point. And again, most of these are just basic changes in the specifics. Not going to dig too much into that. So also in the quality measures, there's 3 measures they plan to move to MVP only: breast cancer screenings, colorectal cancer screenings, and then the BMI preventative care screening. These are the 3 measures, like the vaccination measures, where they moved them to be in the MVP only reporting. And then now they've merged them under what we call a preventative care and wellness measure. This composite measure is the percentage of patients who have received age and sex appropriate preventative screenings and wellness services. This is going to be a measure that is a composite of 7 component measures that are based on these preventative care recommendations. So taking these 3 plus the other 2, and then I believe there's one more that they're adding in on, what was the 7th one? Colonoscopy, BMI, tobacco cessation, and then the high blood pressure. So that, if you're interested, you would need to have access to all 7 of those. And what's crazy is then 1 measure for 10 points versus potentially 7 measures for 10 points makes a big difference if these were measures that you were utilizing in your reporting. So let's talk about promoting interoperability. This does have a change that we've been kind of waiting on for a long time, as they've increased the reporting period to any consecutive 180 days. So we've been seeing 90 days since I think MIPS came about, even back in MU days. Now they've increased that to be 180 days, still giving the same 4 reporting objectives as far as the requirements under the measures, but you will need to increase the reporting time. Also, in promoting interoperability, you must attest to first an ONC certified HIT 2015 edition Cures certified product. You also then need to attest to the actions to limit or restrict compatibility or interoperability of your cert, which is information blocking, the Office of the National Coordinator for Health and Technology Direct Review Attestation, the Security Risk Analysis Measure, and then for this year, they have made the change that the Safety Assurance Factors for the EHR Resilience, which is the SAFER Guide, which was new to last year, but in last year's verbiage, you could actually attest to not completing them and still complete your full PI category. That is changing for this year, and now you must attest to saying, yes, you have completed in the SAFER Guides the high priority practices. So if you did any research or if you looked into SAFER Guides in 23, there are 9 different categories in SAFER, but the only one required to say you've completed is the high priority practices component of the SAFER Guide. So this is new, and it will require that you complete this as part of the PI requirements and to be able to report all of the other components. Second in the proposed changes is that in the PDMP, which became required in 23, there is the proposal to add the exclusion that the provider does not electronically prescribe any Schedule 2 or 4 drugs during the reporting period. So in the current 3 exclusions, it's a little vague, and there's not an exact exclusion for specifically a provider that does not electronically prescribe. And so they've added this as being put into the exclusion list. Automatic reweighting is still in and available in the 24 proposed changes. So small practices who decide that they just want to accept the reweight will not have to participate in the PI category. Small practice is still considered 15 providers or less, just so you know that has not changed. And then as we discussed earlier, the big change is the increase to the minimum of 180 continuous days for this performance period. Any changes in the scoring this year we don't see. We still see the points as they fell this year. We've got a 20-point in electronic prescribing for both ePrescribe and the query of the PDMP. If you are querying PDMP, remember to enroll in your state's PDMP program and ensure that you are able to prove that you have done a query prior to any of the administration or prescription of those Schedule 2, 3, and 4 medications. If you are not prescribing those medications, then again, the exclusion would apply, which I think is most likely what most of ophthalmology is seeing. But if you are prescribing any Tylenol with codeine, that is considered a Schedule 4 medication and would require that query of the PDMP. So be very on top of what your state's requirements are and get enrolled in your state's PDMP program so that you can attest to this if you plan to report the PI category. Now, health information exchange, we still have the standard sending and receiving of the CCDA, and then we have 2 optional, which is your bidirectional exchange, and then the enabling exchange under TEFCA, which is kind of where we'll be moving to in the near future. If you're in a system that does currently, NextTech is not TEFCA compliant, but we are definitely have it on our radar to explore this option so that patient or providers in the future with NextTech could be able to attest under the new TEFCA guidelines. Providing patient access, another good one, 25 points, opening those portals, make sure your patients are getting timely access. And then we've got the 2 required components for immunizations and electronic case reporting. Again, another one in electronic case reporting, it's state jurisdiction. What are those reportable diseases? are there any possibilities that your practice would diagnose or treat that? If that is the case, then you need to initiate that connection with your state. Next Tech is in final stages of completing our ECR testing and certification so that by fourth quarter, you can get that electronic case reporting intent to connect with your state in place to be compliant for this category in 23, and then 24 would be the same. And we still get bonus points for the 3 other clinical data exchanges, something like clinical data registry reporting, which would be the IRIS registry. You still get bonus points for that connection, which is part of our integration with Next Tech to the IRIS registry. So hopefully gives you a good overview of how those work if you're going to report that PI category. Jump into improvement activities. No changes in reporting. It's still any 90 consecutive days, and we still need to demonstrate that at least 50% of your total providers are completing the activities in which you choose to attest to. As far as addition of new improvement activities, there are 5 new ones, and then there were removal of 3 improvement activities. Most of these are not very popular activities for anybody reporting under the ophthalmology specialist, anybody we work with. So I'm not going to spend too much time here, but these are what we're seeing as far as what's going to be available next year. And then I think that's the same screen, just a different look of it. But yep, there's that again. And then we've got modification to 1 improvement activity. So if you are currently using decision support and standardized treatment protocols to manage your workflow in the team to meet patient needs, they are now stating that you need to, you basically have to use CDS tools. So these would be tools within the EMR, not just something that you've kind of built within. They want it interoperable within the electronic health record to give you those reminders as you are within the system. Now getting into the cost category, we're not seeing any proposed changes here. It's still a 12-month reporting period. And again, reporting requirements, claim-based submissions, meaning nothing that we're actually putting out. It is what is seen from those claims. We are going to see the addition of 5 new episode-based cost measures listed here: emergency medicine, psychosis and related conditions, heart failure, low back pain, and major depressive disorder. Again, nothing that should impact the ophthalmology community. And then the removal of 1 episode-based measure, which is a simple pneumonia with hospitalization. The one change we are seeing is that they're looking to increase the minimum case episode to 20 from 10. So for those that are being scored in an episode-based measure, which most will be the cataract episode-based measure, we could see an increase from 10 to 20 in the 24 year for that particular cost measure that I know currently is impacting the ophthalmology practices. I'm not too sure if any of you guys have checked your 22 performance scores, but the final scores are out, and there is scoring in the cost category. In the ophthalmology field, we are seeing it in cataract episode-based measure. We have also seen it in the diabetic care measure, which I know there is some support from the societies in providing an effort to say that this was inappropriately assigned. So if any information, we've got it on our blog in ways that you can hopefully ask for targeted reviews if you were scored in that diabetic cost measure in 22, as it really is meant to be scored by the providers who are managing the chronic care and prescribing medications to do that. So there's some definite new information out now that we've seen this cost score for the first time in 3 years since COVID. So if you need any of that information, we definitely got it on our blog and some different resources on how you can be prepared if you were scored in 22 on those. And then also, again, make yourself heard. This is just the same as saying, hey, we don't understand why we were scored on something. This is a way for you to give comment to the proposed rule. We have 60 days. It closes on September 11th. When you are commenting, CMS 1784-P is the file that you would refer to. And you could do this electronically through regulations.gov or, again, regular mail, express mail, or overnight mail. All right, so that's kind of a quick overview of what we've seen on the key things that are going to be very different next year. So just to make sure everybody's still awake, I'm just going to launch out another poll on, are you looking for ways to improve your MIPS score?
Oh, I love the yeses. We got a lot of yeses coming through.
Yep. I think everybody always is. I know everybody thinks that's probably a dumb question, right? But a lot of times people don't know, like, how do I do it? Where do I go? What do I need? And particularly with cost, it's getting quite tricky to know what you need to do to improve those cost scores. I know the other categories, we've got a lot more resources available to us. So, all right, yep. So I think we've got, again, that 90, almost that, 90-10 split or 80-20 split here on knows and not sure's, both at 9%. So thanks for participating there. And let's talk a little bit about MVPs. So looking into MVPs, these are MIPS value pathways. CMS is committed to the transformation of MIPS through the MIPS value pathways, and this is going to be a new participation framework to be implemented in the future. I know people had been like, sketchy, is this really going to happen? It slowed down a bit with COVID, but they are full force ahead, and there is every verbiage in that proposed rule that we are moving forward in the MVP platform. Why are we doing this? They heard clinicians say that the current MIPS program was too confusing. They believe there's too many choices when selecting measures, which makes the process hard. Many measures are not relevant to the provider specialties, and it's really difficult. Patients can't compare performance between providers when this provider picks this 6 measures and this provider picks 6 totally different measures, but you're both ophthalmologists. How do we really compare that they're, really looking at your quality of care? So due to that, they created the MVP timeline to take traditional MIPS, which is on the left side of this diagram, where we have quality, promoting interoperability, improvement, and cost in 4 separate categories with really no overlay or no, of basically them sitting all in together. So if you see it transfer over to the future state of MIPS, all of our triangles are completely on top of each other. So there's alignment in those quality measures that MVP is tracking. So we're building this framework. It was to be implemented in 22, got pushed to 23 due to COVID. So 23 was the first year you could voluntarily report an MVP. 24, we are definitely see them move forward. There's been some additional MVPs that we could choose from. Nothing yet very specific to ophthalmology, but I'm going to still walk through what this would look like if there was, so that you could be prepared down the line when we do see an MVP for the ophthalmology specialty. So the way that this works is right now it's a voluntary reporting. You actually can do both MVP and traditional MIPS, and you could get scored on the one you do better on. But in the quality performance category, they will provide a list of 8 to 12 quality measures that are very specific to a specific specialty, in which you would select 4 versus previously now we select 6. Then they would also give a list of improvement activities that are very specific to, again, the specialty MVP, and you would pick still 1 high weighted or 2 medium. And then in the cost performance category, they would align any cost episode-based measures to be scored. And then in the foundation layer level, we will see our promoting interoperability category just as it is. And then they've added 1 population health measure. And you will be able to choose which of the 2 of these you want to be included. Once you choose it, then the scoring would be added to that quality performance category. So really you're getting 4 quality measures plus 1 foundational, 2 improvement activities or 1, the cost performance based on, again, the measures that are related, and then you've got the PI category at the foundation level. So looking at some examples, I wanted to at least provide one, even though there's not one related to the ophthalmology group, just to give you an idea of what they're providing for details. So the 5 new ones for this year is focusing on women's health, quality care for the treatment of ear, nose, and throat, prevention and treatment of infectious disorders, quality care and mental health, and then rehabilitative support for musculoskeletal care. This is kind of what you'll see them release. They'll give you a description, and then they'll actually list clinicians who practice in the following specialties may want to consider reporting this NDP. And then again, they'll give that list of quality measures, the improvement activities, and the costs. And this is where you can decide, hey, do I want to report this based off of those options and choose to do the NDP reporting versus the traditional MIPS. So be on the lookout for maybe committees that are looking for people who would like to help write NDPs or create NDPs for the ophthalmology field, because they really do take feedback. And if you want to be part of the word, then I would definitely stay in the know if you could be a part of any of those as these NDPs are created over time. So let's take another poll question, wake everybody up. Are any of you all planning to change software platforms or have a need to understand MIPS better? And I see a question here. I think that the deadline for comment definitely is 9/1/2023. We're not waiting a whole year, so I apologize for that. That is just a misprint in our slide. So funny, these are about the numbers we saw yesterday too. We saw about 50% of you are happy where you're at. 28% are saying yes, you are looking for either help with MIPS or looking to change software, and then 20 of you guys are out there not sure. So anybody on the fence, again, ask those questions. Make sure you get any clarification on those things. Keena, I'm with you. We all need to understand the cost measure, right? It's a confusing one. So hopefully we'll get a little bit of time. And when we get to the end in Q&A, I can hopefully provide a little bit more hindsight on that. All right, well, I'm going to give the controls over to Christy for a little bit just to talk about why you should continue in MIPS for 2024, and we'll take it from there.
Absolutely. Perfect. Thank you, Heather. Great job. I think it was very informative. So why should we continue with MIPS? So it's important because there has been a 9% decrease in the engagement rate of the MIPS eligible clinicians who received a final score. From individual participation between the calendar year 2020-2021 performance years. We know that most of that probably stems from the COVID, the automatic reweight, the automatic hardships that was out there. But it's very important now that we do participate. So top reasons to stay in MIPS. I can't afford to lose any more money on government regulations. Of course, in 2023, earn the 75 points to avoid the 9% penalty. A lot of times, what I hear a lot, and it's very hard for me to stomach sometimes, is people are like, I'm not going to do it at all. I'm not going to submit anything that I have. I don't have enough to get to the 75. Submit what you have. It's on a sliding scale. 0 to 9, depending on your score of what penalty you're going to have. So if you have something, submit what you have so that you don't just get 0 points in MIPS and you will avoid a 9% penalty. Also, you don't want to give your money to other providers. With this program, ultimately the losers pays the winners, so you don't want to be the loser. That's where the money comes from, and so if you're being penalized, it's going to possibly a provider down the street. So you definitely don't want that to happen. And you want to continue to collect more money on your Medicare patients. Very important there. Achieve positive payment adjustment, money back in your pocket. Again, as Heather mentioned at the beginning of the webinar, the scores are out for 2022. There is a lot of controversy with the cost score because, this is kind of the first year that it's really hit a lot of the specialties. So, but you will see in there, depending on your score, there are payment adjustments, positive payment adjustments. So look at that, make sure you're checking it. We do want to make sure that you can get that money back in your pocket. And you want to see great scores on the Physician Compare website. Every physician, it's kind of like Google reviews. You want to make sure you have great Google reviews out there. You want a 5-star score for all of your measures. You want to be that rock star. So those scores can be viewed on the Physician Compare website. So you want to make sure they look good.
Perfect. Yep. And again, I know we might see the 75 points go to 82. I'm pretty sure it's moving to 82. So definitely, I think the best thing to reiterate is anything is better than nothing, because at 0 points, yes, you see the full 9%, but typically this past year was 18.25. It gradually, decreases the 9% up to 0 once you hit 82. So if you submit at least something, you at least diminish that 9% to maybe 4, 3 or 4, but
right.
Just doing nothing is scary.
Absolutely. And I'll add on that just a teeny tiny bit, just because I have seen scores, a lot of different scores. And I did see someone this year that had a 73 points, and it's 0.25% penalty there. So just think about that when you are deciding which way you want to go with that. I know Heather and I both agree. It's very difficult when we see people that just don't submit what they have.
Yeah.
2021 payment adjustments, you can see the biggest thing here, exceptional performer bonus, is no longer as of 2023. 2022 was the last year. So you can see here in 2021 exceptional performer bonus of how it was weighted. But keep that in mind also, that you don't have exceptional performer bonus is gone as of 2023. Heather, do you have anything else that you want to mention on this?
Yeah, so this was looking at basically in the previous years, we had no penalties because they were waived by COVID. So COVID gave an EUC, nobody was penalized. So the bulk of people who saw adjustments in the past were those that participated in the program and got max scores. Even in 22, now that we've gotten a preview and see final adjustments, all the bulk of the percentages up in those that are exceeding performance in the 89 to 100 range. Just so if everybody hasn't looked yet, 100% in 22 is receiving currently in the final preview an 8.25% adjustment. So from 2.33 last year to 8.25 this year is where that exceptional performer adjustment. The max of that, 6% of it, is coming out of that exceptional bonus bucket, and that is going to be going away. But even in the proposed rule, they are reflecting that a maximum positive payment adjustment for 2024 could be 8.82%. So what we're really wanting to make sure is maximum and exceptional performance, even though it's going away, as long as you maintain those high-end scores, there is a way for you to begin to see some of these higher adjustments that we have not seen for many years due to COVID. And we are seeing an 8.25 right now for those in 22 that are in that 89 to 100 range. So I don't know if any of you guys have checked your scores and have seen, but I know we've been doing it with our consulting teams, and there is a wide range, but anybody in that higher end is definitely seeing scores that we've never seen before as far as payment adjustments. Jumping into just some FAQs on how to stay on top of changes. How do I monitor? Where do I find training? How do I know what I scored in previous performance years? And then again about hardships. Should I apply for them? Are there any hardships for COVID? And is it too late to ask for help? So we're just going to walk through these real quick. Staying on top of changes, first and foremost, making sure you're on those newsletters, specifically CMS. We've got our Compliance Corner newsletter that goes out. There's lots of other resources out there of things that you can get on their listservs and just stay in the know, particularly CMS emails, because that's where you're going to see any MVP measure creation, and they're asking for people to join these different committees. definitely through cms.gov, you can sign in there and you would get those type of correspondence. Attending trainings, webinars, definitely all of you are on it, so that's an easy one there. There's a lot out there, just stay in the know. And then you can always ask for help. You can hire a MIPS expert. We have consulting services and meet with our accounts monthly for some we do quarterly. But again, the overall thing is to make sure you just stay on top of these changes, be in the know through some of these different platforms. How do you monitor your MIPS score and max out MIPS points? First and foremost is, know your requirements and run those reports. Look at them monthly, confirm that MIPS score, run your PI reports if you're going to participate, know where you're at month to month. Don't wait till fourth quarter, run the reports and think you can fix things. It's just not very doable anymore with the benchmarking that we're seeing, is they pretty much expect perfection. So if you're not managing to perfection each month, getting at the end of the year, it's going to be very difficult to get those max scores. So when you look at monthly results, you can address those gaps quickly, and again, get them into those higher percentages and keep them there. Training staff, following up to ensure they're consistent. Just because you're great one month doesn't mean that they're going to stop hitting that cessation tobacco, finding in the note moving forward. So you definitely want to make sure you train them and then stay on and be consistent. And continually check with your EMR vendors for updates on regulatory items. Things change. I know in our compliance corner, we try to keep you up to date when we see or have things that are changing due to requirements on the government on our end. Where do you find training materials? I always kind of find this, not everybody knows that in the compliance corner, in the NextTech community portal, we have a compliance university. In that compliance university, we have by platform videos of how to meet ECQM measures, how to run your reports, how to set up the quality assistance tool in IntelliChart Pro. So various things like that. We've got all of those resources there. Make sure you've got somebody in your practice that has access to the community portal. We also add things out there. So go there, check out, see things new. Make sure you're staying in the know on what you need to know about the software. How do I know what I scored? Like we just said, they just released the final scores. Log into your QPP account. If anybody on this call does not have a QPP account, or somebody in your practice does not have a QPP account, you need to get one. Mainly too, because it's the only place where you can get your cost measure details. So now that we're seeing those details, we haven't seen them for 3 years. We definitely have them now. And then you want to make sure that you can open them and see what you were scored, so you can project that and use that data when prepping for next year. This is kind of an example of looking at what you'll receive. It'll show you that adjustment, again, base adjustment versus exceptional performance bucket, but all of that will go. All right, should you apply for the hardship application for PI? Again, preference of the practice. There are options available. First and foremost, if you're a small practice, it's automatically applied. Then there are ways that you can ask for the hardship if you've had a decertification of your EMR, insufficient internet, extreme and uncontrollable circumstances, or you have lack of control over the availability of certs. PI hardships, I'm kind of, here and there on. It just depends. If you can max points in quality, you're a small practice, then it's really not an impact. But if you need points, report PI. It's something that would gain you more points towards that score, and again, increase the potential of not getting those penalties. Are there hardships for COVID in 23? Yes, it is still an option. There is an EUC hardship every year. There are other reasons that you could apply for EUC. COVID has been a reason, and it is still available. But be very, conservative in just choosing it for no reason. We have heard that they will begin to audit, and in auditing a COVID hardship, they're looking at payroll. They're looking at, where and why could you not collect this data necessary for the performance period? What really caused you to be unable to do that? So basically, you want to make sure that you can support it, and not just support it for a week, but support it for a long period of time, meaning over 3 months of being able to collect that data thus impacting your overall score. So those are some of the things that are available, but just be conservative on that. Is it really the reason you're not able to collect that quality measure data, or are you just using it kind of as a crutch because you would hate to get caught back through an audit and not be able to prove it? Common worries and themes. Is it too late to ask for help for MIPS? I mean, to me, I don't think it's ever too late to ask for help. We do offer MIPS health checks. We also have attestation packages with the monitor and the master. They are subscription-based. You can sign up at any time. We'll jump in and begin where you're at. Like both we and Christy said, any point is better than no point. So even if it's towards the end of the year, we'll jump in and at least try to gather as much information as you can to successfully attest and be compliant and avoid any penalties at the max. So I know that's kind of a lot of quick stuff, but all important stuff to stay in the know and on top of it and why you should participate. So last poll question before we jump into some Q&A. Are you interested in receiving assistance with your MIPS strategy to ensure your MIPS success? So we'd love to be able to reach out and talk to you about our services and get you some more information if you need it. All right. Putting our percentage is it's like consistent over and over. Pretty cool. And then before we jump into the Q&A, I want to make sure you guys get a quick snap of this screenshot. This is our MIPS to the Max toolkit. Something new. It's all things MIPS in one powerful toolkit. There is a link at the bottom where you can download the toolkit. It does provide an ebook on the 10 tips to maximize MIPS, everything you need to know, blog posts, a MIPS milestone calendar, and a MIPS checklist infographic. So this is a really cool new component that we've added to this year's reporting for resources for all of you that attended and want to make sure that you can access this information. All right. So I am going to, Christy, you want to grab some questions?
Yes, absolutely, because I have been going through, just so everybody knows, I've been going through answering some questions, messaging back and forth. So so just look at that, make sure you're getting those. I do have one that I did want to address. First of all, make sure that everybody knows that you will get a copy of the webinar so that you can view it at a later date. So yes, anybody who's signed up will get a copy. I've had that question asked a lot, so I just wanted to address that. And then second, I've been speaking back and forth about the closing the referral loop, kind of stating that the information they acquired from the portal does not seem to be working. So there's a couple of things when it comes to that without knowing exactly what is not working. So if you're not getting patients in the denominator and you're opening the loop, but you're not getting patients in the denominator, it could be because the criteria of that denominator is not being met. What I do notice sometimes with this specialty is maybe an office visit wasn't billed, and you have to have that office visit billed for that to, for those patients to show up in the denominator when you're doing a referral loop. So keep that in mind. If it's a numerator issue and they're not going in the numerator, then there has to be something that's going on with the loop that is not being closed.
And let me clarify too, there is always a little bit of confusion, specifically in IntelliChart Pro, between the closing the referral loop quality measure, and then in the promoting interoperability category, we have the sending and the receiving of the referrals. And it does live in the same area in ICP where we document the denominator, or we get them into the measure by documenting you referred, patient A to Dr. Joe, and you could do that from within the chart, and then it becomes in the communication tab, you can see that referral. Then to meet the measure for the promoting interoperability category, all you need to do is state underneath it that communication went out via secure email, and it was sent using direct email and the CCDA document. So it's got a lot of technical electronical exchange in a secure fashion. And it does not require that you close the loop, because it's just stating that, one, you've sent out a CCDA to a referred provider. Then you have to document that you've received one and reconciled. For the referral loop quality, we can send out the referral in the same section of IntelliChart Pro. In the drop set, it does not require us to say that you have to use direct messaging. For the quality component, it can be faxed, it can be given to the patient. But the one thing that's different in the quality one, in order for it to be met, you must receive back from the referred provider a consult report. That consult report can come to you in any fashion, but in that communication tab, the date needs to be documented of when that report was received to close the loop. So I don't know if that helps at all, Tina, with the confusion there, but there are two separate workflows, one for promoting interoperability, and then the other. I don't know if that's the discrepancy you're seeing, but
right. And then one of the biggest things with that is, remember, if you're using referral loops, all of your referral loops will count in the denominator of your PI, as Heather was counting. So even if you don't send them electronically, it's still going to count in there. So I want to make sure we can hit a few more questions, but Kina, if you have more questions on that, reach out to support, and then maybe someone can reach out to us and give you more, but hopefully we've answered that question. I would say my next question here is, how can the office increase their cost scores? I just looked at our final score and it was only 12.63 out of 30. Thank goodness our other measures were maxed out, or else we would have been in trouble.
Yes. So, Mrs. Stacy, the thank goodness our other measures were maxed out or you would have been in trouble is exactly it. And I will say, I'm assuming you're talking about the cataract cost measure, as this was one that impacted practices on a very wide range with a very limited difference in cost. So if you've looked at the details of your cost score, you can go download your data file. You can see your eligible patients that were scored. You can review this data, and you can submit targeted reviews if you feel this data is not valid. But I will say, when you look at the benchmark of this cataract measure, the difference from those that are on the low end, which was $2,900, I'll do the numbers to be exact. We were, low end was $2,914. So anybody's average that was $2,914 would have gotten max points in cost. So you were saying you got 12.63, so you probably had a higher average, but that average was probably less than $300-400 from the low end. So we have a very tight benchmark. So you really are going to have to dig into those data files and determine if there's any type of services that you have been providing that you could not provide in order to save that difference. Now, I know that's very difficult to say, well, how do I know what where's $200? Where can I find $200? But that tight benchmark has made it very difficult for many practices to be able to say, how can I really improve it? So my best guidance can be, understand the measure, pull the code folder down, know that you're coding correctly cataract surgeries. There are exceptions that can be applied for comorbidities. If those comorbidity diagnoses are not getting on your claim forms, you are getting scored on those patients. So you want to make sure that all coding is being done and following the coding parameters of the cost score. So I can only express that you must understand the measures, review your data, which they just released, and understand, can you make any adjustments, or at least if you have questions on your data, you have the next 60 days to submit a targeted review and clarify it. So that's what we're doing with a lot of our groups that have been impacted the same way. They just scored on the lower end of it, but it's really a very short, small amount of dollar. You know, how can we help them determine where they could maybe do some services differently and get on that low end? I hope that's helpful, because it's definitely something that a lot of your field is experiencing from the 22 reporting.
All right, so let's look. I want to hit some of these. I have had, Brittany has asked, with the PDMP search in PI not being optional, is there going to be a change in license pricing to allow more providers to be able to e-prescribe?
I don't believe there's a license. Yeah. If you need it, if you don't have them available to prescribe in, that's an interesting one. I'd have to understand the details a little bit more.
Brittany, we are not absolutely certain on the pricing when it comes to these things. We're the consultant on the other side of it, but the pricing. So that, to me, that would be something that I'd have you reach out to your client success manager and speak to them about if that is a concern of yours. We just recently switched our EMR to NextTech. How will we report from two different systems? We got a quote for a service that will help with that, but the price seemed excessive.
So another, again,
Heather, I think I'm losing you a little bit on it.
Again, it'll really depend on your two EMR systems, and if there's a way for you to integrate them using a registry. Again, would probably need a little bit more details to know exactly the best solution for you to be able to merge that data.
So I did want to hit this one just because Stacy was stating that they had a 2.09 on diabetes and a 6.32 on cataract for their cost score.
So for the diabetic measure, there is a possibility, a targeted review being submitted, letting CMS know that it has been inappropriately applied to your specialist is how I would handle that. And then hopefully that would be removed after your targeted review. The AAO, ASERS, and the Retina Society have written a letter directly to the CMS about the diabetic measure. I'm sure you could find it if you're a member of AAO. I know that they released this letter. You could add that as an attachment to that targeted review so that you could hopefully get approval that it would get removed. And again, Elisa, I mean, are we banking on them to get it removed? Yes. And if you needed to review it, we started looking at a couple of the data files for diabetic measure, and there are a lot of things included in that are outside your scope. It really just looks at your two ophthalmology visits, and then it's got a lot of attributed costs that are coming from other providers. So it'll be an interesting one to look at. I would say in retina world, it could be your injection cost because those do get pulled in there. So that would be one thing that you could consider, but it would take some digging into the details.
All right, so we are at the top of the hour here. So I just wanted to see if we could hit this one really quick, just because it's been sitting out here. We have the ERX waivers for our doctors for controlled substances. Does this exclude us from that section of PI?
And when you say ERX waivers, is that your state allows them because they can't prescribe electronically? Okay, then yes, I believe those are viable because your state doesn't, and it will be that your jurisdiction doesn't allow for electronic prescribing.
And also keep in mind the automatic reweight for the small practice. If your quality is maxed out, and then you still have that option for that automatic reweight for PI, which then it wouldn't be this, the PDMP, ECR, things like that would not actually pertain. So just kind of keep that in mind. You can choose to submit if that's what you want, even if you're a small practice, but I just want you to keep that in mind. All right.
I think we got the majority of everything, but we'll go through if we missed any. I know we're getting right to, we're actually 2 minutes over, but I do see where we've got some definite consistency, and be on the lookout for some cost stuff. We've only had about a week to really look into these details now that we've got data files. So we'll be pushing out more and more resources before the deadline, which is October 9th, to submit targeted reviews. So keep your eye out. There's no rush. We've got until October 9th. So we're trying to really make sure when you submit that targeted review, you've got everything to support it, because you can't submit more than one. So we want to make sure we've got everything we need. So.
All right, everyone. Thank you for joining. I hope you got some valuable information off of this, and have a great day.
Thanks, guys. Have a good one.